Thank you, Dr. Samiksha. It's a privilege to be a part of this session. And Chairpersons, Anita, thank you. Thank you to the Scientific Committee and Fairuz for this opportunity to be in this session. And we've had a wonderful start meeting everybody with the wonderful lacrimal session. So I'll be starting about the importance of evaluation and decision making for the ptotic eyes. As we know, decision making in a diverse condition like congenital ptosis can be difficult, and a good evaluation is critical to it. The congenital ptosis has many variants, and acquired ptosis has many more variations. So an evaluation, like anywhere else, begins with a good history taking, followed by examination. The evaluation, the history taking, helps us to differentiate the congenital from an acquired condition. It helps us look for any predisposing factors, any variability, any previous surgical procedures, and a possible family history as a contributory factor. Examination should never forget the general examination, which would hold a clue in a number of conditions, especially those with systemic associations, such as oculopharyngeal dystrophy, CPEO, myasthenia, or several other conditions. And same is true for a neurological examination in particular. But having stressed the importance of these, we'll proceed to the ophthalmic examination. Like elsewhere, visual acuity and association of refractive errors is crucial, and we know the specific associations of astigmatic error and amblyopia with ptosis, especially congenital ptosis, which may occlude pupil or cause refractive errors. Pupillary examination is important both in congenital and in acquired conditions where the etiology may be linked, such as a third nerve palsy, a Horner syndrome, and many other conditions. One of the usual helpful signs in differentiating a congenital from acquired is the effect of dystrophy in causing a poor relaxation, causing the eye to look larger in a congenital ptosis than in an acquired ptosis. External examination can be contributory, where mechanical ptosis may be due to an associated lid mass or any other pathology, either conjunctival or the eyelid. But a congenital ptosis or an acquired ptosis must be quantified, and this begins with a measurement of the palpebral aperture. Both the vertical and the horizontal must be assessed. Vertical is particularly important, and the scale, a transparent scale, is a crucial implement for this. So measurement of margin reflex distance, which is the distance from the reflex to the center of the eyelid, is a very useful measure for comparison and for assessment of the amount of ptosis. So we can gather the amount of ptosis either by comparison with normal values or by comparison with the other eye, which helps us grade the ptosis into mild, moderate, and severe. Ocular motility assessment is very important, as we'll see that there are a number of associations both with congenital and acquired ptosis. Levator action is probably one of the most important things which helps us determine the nature of surgical procedure. So the excursion from down to up gaze while the frontalis action is blocked is a critical measurement, which again helps us quantify or classify the levator action. Measurement of the margin crease distance in the downward gaze is again useful, as it helps as a standard for preparing the incision on the ptotic side. Both sides must be measured. But a tarsal platform show, or the amount of the distance or the principal lid crease from the center of the eyelid, is important in decision making and in diagnosis. But Herring's law must never be forgotten. As an example, a ptotic eye may droop further when the more ptotic eye is lifted, as you can see here. So Herring's law must be kept in mind when making decisions regarding the management. Presence of Bell's phenomenon is again critical for protection, and so is corneal sensation when the lag of thalamus in the post-operative period may be present. Phenylephrine test is particularly crucial where we assess the elevation with phenylephrine in those cases where we are considering a Mueller's muscle procedure. We must look at all the possible associations as well, and we're all aware of the associations. Jaw winking ptosis in our center constitutes almost 1/6 of the cases, and you must, besides severity of ptosis, assess the excursion of jaw winking and the associated motility problems which are present in up to 50% of the cases of jaw winking. Blepharophimosis syndrome, again, a familial condition, autosomal dominant transmission with its characteristic features, needs to be diagnosed and managed. Ocular motility disorders, an important condition that is to be kept in mind is this. So an apparent drooping here, which gets corrected on covering the other eye. So this constitutes the pseudotosis, which must be kept in mind and differentiated from a true ptosis with ocular motility defect association. And a condition like this can be corrected just by squint surgery so that the ptosis disappears without any ptosis surgery. The other associations in congenital or acquired need to be looked at. The commonest are superior rectus underaction and the monoocular elevation defect, which are present because of development of the superior rectus from the same myotome as the levator palpebrae superioris. A congenital third nerve palsy, presence of horizontal deviation, or a CFOM, congenital fibrosis syndrome, are other important associations. Amongst the acquired disorders, you need to take into consideration the presence of chronic progressive external ophthalmoplegia and myasthenia gravis as some of the most common associations. But other muscular dystrophies and third nerve palsy may be important causes of ptosis. We need to look at the entire array, and we'll go through some typical examples: pseudotosis, involutional, neurogenic, myogenic, traumatic, and mechanical, where appropriate evaluation will be critical. So CPU with its classical features is usually easy to diagnose and can be managed appropriately with conservative sling procedures. Suspected myasthenia, the ophthalmic tests available help us make the diagnosis, although contribution from RNST and the serum tests again is very useful. So this is an illustration of an 18-year-old male presenting with no history of diurnal variation, but an eye test gave us the diagnosis within 5 minutes. This is another patient with restricted motility in all directions, asymmetric ptosis, corrected after neostigmine injection. But aponeurotic ptosis is possibly the most commonly seen acquired ptosis, and a moderate to severe ptosis with very good retained levator action and a listed lid crease. Apparent thinning above the tarsal plate, which can be felt, is again a very important clue. And levator aponeurosis reattachment, or at times a Mueller's muscle resection procedure, help correct this condition well. We see these cases in India in the young as well, and reattachment of dehisced aponeurosis serves the purpose very well. Amongst the myogenic cases, there may be an association like this, where we had a normal pupils, restriction of motility in several gazes, and we found the association with myositis. So a myositis associated with involvement of the levator complex would lead to a myocytic non-specific orbital inflammatory disease will be the diagnosis, which can be corrected by your therapeutic measures such as steroid. Neurogenic ptosis may present like this, and like in this elderly man, where there was complete ptosis, restricted motility, and no perception of light. So here we could find the cause as a metastatic carcinoma tongue at the orbital apex. Traumatic ptosis again needs to be assessed and corrected appropriately. Mechanical ptosis, such as in a neurofibromatosis case here, again is tackled as removal of that mass. Now, decision making in congenital ptosis is regarding the appropriate age for surgery and the appropriate choice of surgical procedure. In most cases, we operate at more than 3 years of age, whereas for fascia lata sling surgery, where autologous fascia is to be harvested, the age is 4 years, except if pupil is covered, when a procedure may be done in early infancy. Of course, there are studies in blepharophimosis syndrome and other conditions that even if pupil is partially covered, there may be ptosis and they need to be done early. So decision is based on all the factors that we spoke about earlier. Amount of ptosis, levator action are most critical, which help us choose between a Fasanella, levator, or a frontalis sling surgery. So ocular motility disorders, wherever present, must be tackled first. In acquired ptosis, basically the etiology is based on management of the cause and then management of the ptosis. So appropriate correction of the cause helps in taking care of the acquired ptosis as in an acquired aponeurotic ptosis. Thank you very much. Hope the subject is at least reasonably covered. Thank you.
Thank you so much, Doctor. We are glad that you finished it on time. Over to the moderator.
It was very extensive and the photographs really helped in the understanding much better. So I would like to ask for your input on how you deal with Marcus gun phenomenon, since you said 1/6 of your patients do have it. So how do you normally approach them?
I think that's possibly because of the referral bias, because I've been doing jaw winking for a long time. I think the basic things that you need to decide are the extent of ptosis and the extent of excursion. If the excursion of jaw winking is only about 2 millimeters, at times you can just correct the ptosis, possibly by a Fasanella servet or a levator procedure, whatever is appropriate, and let that jaw winking be. There are those who do have jaw winking without any ptosis either, but usually they have mild jaw winking and they can be left alone. Those with a significant excursion, it is important to take care of removal of that excursion and levator disabling by a complete excision, including the horns, is the way to do that. And that must be corrected. The ptosis that you create is best corrected by a sling procedure, a frontalis sling procedure. You can do a silastic sling procedure unilaterally, but the disadvantage is the asymmetry in down gaze, and that is best corrected if you do a bilateral levator excision with bilateral fascia lata sling, which allows a perfect symmetry to be achieved in those who are willing for it.
Thank you so much, sir.
Yeah, thanks, Dr. Grover. And that's the question actually I wanted to ask you, because a lot of us find it very difficult to convince the patients with unilateral ptosis to go in for a bilateral surgery. But I agree with you, the overall cosmetic result is much better in a bilateral. And I think if we believe in it, what do you say? So how do you convince your patients to go in for bilateral?
So as I said earlier, it's the conviction of the surgeon which matters. So once you are convinced that you're doing the best for the child and for the patient, then you are very easily able to convince the parents. It's because you say it as a matter of fact thing. In fact, when I am reluctant at times and I advise a unilateral procedure, because maybe I have a long list, the parents, unfortunately, many of the parents have heard about the bilateral procedure, and that's why they have come to me and they insist on a bilateral procedure. So it works both ways at times.
I guess, as Dr. Grover said, it's basically a surgeon's conviction. Somehow I could not ever gather that courage of doing a bilateral surgery for MGP correction. So in my cases, I generally tend to make the patient or the attendants understand that after improving the ptosis, the excursion will decrease. So anyway, the Marcus gun phenomena would decrease, and it would not be so, bothering to the patient as it was earlier. But definitely, with Dr. Grover sir's experience, I guess we need to learn how we get convince ourselves as well in times to come.